Associate Program Director. Dr. Mari Kai did medical school at Columbia and residency at OHSU and is currently our residency program director. They both were recently awarded a $100,000 grant through the Transformation Council here at Providence to study the treatment of opioid use disorders in primary care and have ongoing research in that area. And today they are going to be talking about the research and project as well as an overview of the treatment of opioid use disorders in primary care. Brinton and Mari, thank you.
Can everybody hear me? Is my mic on? No. On now? Okay. He's giving the thumbs up, so I'm not sure what's happening. Okay, great. So as Liz said, I'm Brinton Clark. Thank you so much for having us speak today. Mari and I are really excited to talk about this topic. This is something we've been doing for a while now. I have had a bad cough, and I'm going to do my best here to get through this without coughing today. So I'm going to start off with a couple of cases from my own practice, just to kind of lay the stage for what kind of patients we might be treating with medication-assisted treatment for opioid use disorders. So my first case is a 20-year-old man. He was 20 when he presented to me, and he had been prescribed Percocet at age 15 for a dental procedure. And he found he really liked how that made him feel. And I think that the reality is that there's going to be that subset of patients who are going to react very strongly to opiates and for whom opiates are going to have a real predilection to create addiction. So he started using opiates recreationally in high school, and then he found he was using them increasingly to the point that he was starting to use them every day and really feeling like he was dependent on them. He was being seen by a doctor in Eastern Oregon and was prescribed quite high doses of opiates for many months for undefined abdominal pain, probably pretty inappropriate prescriptions. And I think at some point the doctor decided that this was bogus and cut him off abruptly. And so he started buying prescription opioids on the street. He was arrested when he was 18 for writing false prescriptions and attended a court-mandated treatment program. And he stayed clean for about 4 months at that time, but then ended up relapsing. And by the time that I saw him, he was buying 150 milligrams of oxycodone on the street and every day, which is obviously both pretty dysfunctional but also extremely expensive. His use had caused him to lose jobs in construction. It had strained many family relationships, and he was largely estranged from his girlfriend and 2-year-old daughter, which he was quite upset and sad about. He was highly motivated. He really wanted treatment. He tried to get off on his own multiple times, but the withdrawal was always too difficult. So he didn't think he could be successful without medication-assisted treatment. And the second case I'd like to present is a case of heroin addiction. And just to compare that, really, prescription opioid addiction and heroin addiction are really treated very similarly. They're very similar. They are really the same disorder. And so sometimes in our mind we might think, oh gosh, heroin's so much more serious, but actually it's treated really the same way. So she'd been using heroin for about 5 years. She'd initially started with prescription opiates, using recreationally. After her mom died, she found that she was getting increasingly addicted to them. And then she transitioned to heroin because of the cost. And I think that's also another common theme to emphasize, is that people who are using heroin today, most of them have had the gateway of prescription opiates. It used to be in the 1970s, people who were heroin addicts in the 1970s started with heroin. That's not so much the case anymore. People are starting with prescription opiates, and then they can't afford them anymore, and so they move to heroin, which is much cheaper. This woman had tried being in a methadone program, but she found that methadone made her feel high, and she didn't feel like she was successful in that program. Her husband also uses heroin. She had been previously able to work full-time, but is no longer able to work. They have 2 teenage children who live at home and are pretty upset that their parents are using heroin. She's tried to quit unsuccessfully multiple times. She's anxious, depressed. When I saw her, every visit was a lot of crying. She has very low self-esteem and a great deal of shame about her use. She is highly motivated to quit, but doesn't think she can be successful. So what we'll be covering today, we'll be talking about the epidemic of opioid addiction in the United States. We'll be understanding how physician prescribing contributes to that opioid epidemic. We'll be exploring why primary care may be an appropriate treatment setting to treat many patients. We'll learn to diagnose opioid use disorders in primary care, and then we'll be talking about the medication assistance options to treat opioid use disorders in primary care settings. We'll understand the current state of physician treatment capacity in the United States and in Oregon. And then we'll be talking about our clinical transformation project at Providence that's focused on expanding treatment with buprenorphine. So I know there's been a lot of coverage of the opioid epidemic in the United States. And this slide shows the overdose deaths from opioids that have occurred in the last little over a decade. And there was a huge increase, 270%, or let's see, let me make sure that's accurate. So 47,000 people in 2014 died from substance use overdoses. And the majority of those were from opioids. And at this point, the deaths that are from substance abuse overdoses now exceeds motor vehicle accidents. So you can see that there was a rapid climb between about 2000 and 2010. And then the prescription opioid overdoses is kind of leveling off since 2010, I think, as we're starting to change prescribing practices. However, you can see that heroin deaths were kind of stable, and as this is leveling off, heroin overdose deaths have tripled in the last 3 or 4 years. In Oregon, there were 500 deaths from opioid overdose in 2014. And the costs associated with substance use disorders is over $200 billion. So this is a very, very costly problem. Looking at addiction statistics, in 2014, it was estimated that 1.6% of the US population aged 12 or greater used prescription opioids for non-medical reasons. That's 4.3 million people. In terms of actual addiction, about 1.9 million people have an addiction to prescription opioids, and nearly 600,000 have an addiction to heroin. So putting those together, it's about 2.5 million people in this country that have an addiction to opioids of some form. And nearly 80% of those patients do not receive any treatment. So there's a huge gap in treatment at this point. So what's been the role of physician prescribing in driving this? Looking at sales of opiates over a little over 20 years, between 1991 and 2013, the sales of prescription opiates went up by 270%. There's just a huge supply of opiates available. At this point, the US consumes 80% of all prescription opiates, and we make up 5% of the world population. We consume 99% of the world's hydrocodone. So we are using so many more opiates than other countries. In 2010, you can see that wasn't quite the peak year of opiate prescriptions, but in 2010, the CDC estimated there were enough prescription opiates prescribed that every US adult could use hydrocodone every 4 hours for a month. That's just a huge number of pills that are out there. And the reality is many of these end up on the street, being sold on the street. And so this is really part of what's driving the epidemic of opioid use. And lest we think that Oregon is not part of this problem, actually Oregon, this is from 2012, and this looks at number of painkiller prescriptions per 100 people. Oregon was in one of the higher states, not as bad as a lot of these southern and Midwestern states, but we were prescribing between 82 and 95 prescriptions per 100 people in our state. So we're using an awful lot. So looking at addiction treatment models, I think the traditional model of addiction treatment is to really shunt people into specialized addiction treatment settings, and that there's kind of the Great Wall of China between primary care and addiction treatment, and that we're having traditionally not as much overlap and not as much communication. And that probably needs to change, and I think it is changing. So some of the traditional addiction treatment settings that people might be referred to, detox, which involves very short-term tapers usually to get them off of medications over a week or two, inpatient residential treatment programs, residential sober living, intensive outpatient treatment programs, mutual support groups like NAAA or Smart Recovery, and then individual psychotherapy or psychiatry. I think increasingly we're realizing that there's a real role for primary care in treating addiction. And the reason for that is that there are just not enough addiction treatment centers to treat everybody with an opiate use disorder. We know that only about 1 in 10 patients who have an opiate use disorder are in any form of specialty treatment, and that primary care can increase that access greatly. We also know that there's a lot of stigma attached to opiate use disorders, and many patients are just not willing to seek treatment in traditional settings. But primary care can be a gateway where they may feel more comfortable. I think treatment in primary care fosters that acceptance that opioid addiction is a medical condition. The skills that we use in primary care to address behavior change, such as smoking cessation, such as treating patients with obesity or diabetes, are common to what we use to treat addiction in many ways. And I think the other understanding that we're increasingly having is, rather than thinking of addiction as a moral failing, we're increasingly starting to think about this as a chronic brain disease. So we know, and I'll talk more about this, that when people use opioids chronically, their brain changes. And this is really a chronic disease. It has periods of remission and periods of relapse, like many of the conditions that we treat in primary care. We're very good at treating chronic disease in primary care. And so the chronic disease model works well for addiction. And finally, short-term treatments we know are less successful. When people go into detox, they oftentimes relapse. Most patients need longer-term treatment, and primary care can be a setting in which we can offer that longer-term treatment. So I'm going to talk a little bit about the neurobiology of addiction, just to emphasize this really is more of a chronic disease. So it's clear that some people's brains are more susceptible to addiction, and that probably relates to both genetics and environmental factors. So we know that opioids stimulate the mesolimbic reward system in the brain through release of dopamine and other pathways. And use of opiates causes a hyperphysiologic release of dopamine. And that leads to feelings of pleasure and well-being. However, the brain is going to try to come back into equilibrium, and so it's going to try to release less dopamine. And so what happens is when patients are doing activities that used to be pleasurable to them, that may be having a meal with friends, it could be taking a walk, it could be reading a book, they have such a low level of release of dopamine with those previously pleasurable activities that they feel dysphoric, they feel agitated, they feel malaise. And so that creates a cycle of craving. So now they're going to crave the drug because the only time that they feel normal or in any way good is when they're using the drug. So they have this new set point. We also know that there are deficits that are created in the prefrontal cortex. So our prefrontal cortex is what helps us control our judgment, planning, executive functions. And in the normal brain, the prefrontal cortex helps overcome some of our impulses for immediate gratification in favor of longer-term goals that may ultimately be more satisfying. And that happens by inhibiting the signals to the reward system. There are probably some deficits in the prefrontal cortex in people susceptible to addiction, but we know that when people are using opioids chronically, that prefrontal cortex operates less and less effectively. That prefrontal cortex changes. And what that means is that patients have even greater susceptibility to impulsive behavior and to lack of control. So the brain is really fundamentally changed once people have developed an addiction. These changes may take months and even years to resolve after abstinence, and we don't really know if they can ever fully resolve. So we're really understanding this more and more as a chronic medical disorder. So how do we diagnose opioid use disorder? I'll just go briefly through the DSM-5 criteria. First is that opioids are taken in larger amounts or for longer periods than they intended. Second, they have a persistent desire or unsuccessful efforts to cut down or control their use. They spend a great deal of time in activities related to their opioid use disorder. They have craving or a strong desire to continue using. Their use results in failure to fulfill obligations at work, school, or home. They use despite causing social or interpersonal problems. They may be giving up activities that they previously enjoyed or occupational activities. They're using in situations that are physically hazardous. They continue to use despite the knowledge that they're causing problems. And then they have tolerance or withdrawal. For patients who are prescribed opiates medically, these two criteria alone do not equate to an opioid use disorder. They need to have other features. So patients who have a mild disorder or considered to have 2 or 3 of these criteria. Patients who have a moderate use disorder have 4 to 5 of these criteria, and patients who have a severe disorder have 6 or more of these criteria. And I think if we wanted to summarize addiction quickly, it's really represented by craving and loss of control or compulsive use despite harms. So I'm going to talk now about medication-assisted treatment options. I think increasingly we're realizing that this really helps patients. And the model of total abstinence is maybe not realistic for every patient. So there's 3 options to treat opioid use disorders. Methadone, I think we're all very familiar with. It's been around for quite a few years now and available in federally regulated treatment centers only, not available in office-based settings. It's a pure opioid or mu agonist without ceiling effects, meaning it purely stimulates the opioid receptor. Buprenorphine, which I'm going to be talking a lot more, known under the trade name Suboxone, is a partial opioid agonist and a partial antagonist. So it partially stimulates the receptor and it partially blocks the receptor. It does have a ceiling effect, and that tends to make it safer. Physicians who want to use this in an office-based setting are required to get a waiver from the DEA. The 2000 Drug Abuse and Treatment Act was passed by Congress in the year 2000, and this allowed physicians to prescribe buprenorphine in an office-based setting to treat opioid use disorders. And then finally, the third option, which Mari will talk more about, is naltrexone. And naltrexone is a pure opioid antagonist, meaning that it blocks the effect of opioids on the brain, and it probably has less effect on controlling cravings. So that is one feature that Mari will talk more about. And this slide kind of demonstrates what I just said, but here's the opioid effect. Methadone, the more you give, the more effect you have on the opioid receptors. Buprenorphine has an effect which then has a ceiling even if you go to higher doses. So it's starting to block the receptor at this point. And then naltrexone, purely an antagonist, has no effect on the opioid receptors, actually just blocks them. So I'm going to be talking more about buprenorphine and how it works. Again, it's a partial antagonist and a partial agonist. It stimulates the opioid receptors, and that reduces withdrawal and craving. It's actually a very effective medication to stop the withdrawal and craving for patients who have stopped their opioids. At higher doses, it binds very tightly to the opioid receptor, so it blocks the action of other opiates. What that means is that if you give this medication to patients who are taking opiates and haven't started going through withdrawal, you'll actually put them into withdrawal because it's then kind of taking the opiate off of their receptors. So this medication is actually started when patients are in opiate withdrawal. And if it's given in that setting, it will control their cravings. If people are taking a little bit higher doses of buprenorphine and then they use heroin or they use other opiates, they don't really feel the action of those other opiates because the receptors are blocked. The ceiling effect means that there's much less euphoria. Patients that I treat tend to tell me they just feel normal on this medication. They don't feel high. There's much less risk of respiratory depression and less risk of physical dependence. There have been cases of overdose of buprenorphine. They've almost exclusively been in a case where people have been using other sedatives such as benzodiazepines. So in and of itself, it's a much safer medication than opiates. There is some analgesia, but probably not as much as from pure opiates. It can be abused. It's usually a drug of secondary availability, so people who are addicted to opiates and can't get them for whatever reason will sometimes buy buprenorphine on the street to control their cravings, but it's usually not their go-to drug. It's often paired. The drug Suboxone is a pairing of buprenorphine with naloxone, and the reason for that is to reduce misuse. If it's used sublingually, which is the correct method of use, the naloxone isn't really absorbed, and they only absorb the buprenorphine component of it. However, if people attempt to inject this medication, they will actually go into withdrawal because the naloxone is then injected. So people learn pretty quickly that they don't want to do that. Physicians need to have a DEA waiver to prescribe this medication. That requires an 8-hour training course, usually done online, pretty simple to get. Once that training course is done, you can apply for a waiver, and that's quite easy. And with a waiver, you can treat up to 30 patients in the first year, and then you can apply for expansion of your waiver to either 100 or 275 patients. So when we treat with buprenorphine, the goals of our treatment are to eliminate withdrawal symptoms, to decrease or control cravings for opiates, to eliminate other opiate use. So we don't want people, what we're trying to do is have them stop using their opioids. We want to maximize their functional status, allow them to participate in behavioral and psychosocial interventions, and that's something that we require. They must be in behavioral treatment. Medication-assisted treatment is not enough treatment alone. We want to improve their health overall. Oftentimes this is a way that people can engage in primary care and start to address other health problems that they may have been failing to address. And also, if that patient is an injection drug user, what we're hoping to do is either screen or prevent them from getting either HIV or Hep C. And most patients are able to stabilize on a dose of 8 to 24 milligrams daily. I'm going to talk a little bit about the efficacy of buprenorphine. Most of the data that I'm presenting here is data from the Cochrane systematic review. There was a systematic review done in 2008 by the Cochrane Systematic Review. And this first slide looks at retention in treatment. So are we able to retain patients in treatment better if they're on buprenorphine? And this shows that, and I'm realizing this slide isn't super clear, but this shows that looking at these studies using buprenorphine in moderate to high doses, there is clearly a benefit to buprenorphine in retaining people in treatment. And the risk ratio for retention in treatment is 1.82 if patients are using buprenorphine compared to placebo. The other thing we want to see is, are they not using opioids anymore? And so what do their urine drug screens look like? And there's a clear benefit to buprenorphine in reducing positive urine drug screens for opiates. What about comparing buprenorphine to methadone? So we know methadone's been around for a long time. We know that it works. And what the studies have found at moderate to high doses of buprenorphine is that there's relative equivalence to methadone. There's a slight non-statistical trend towards superiority of methadone at moderate doses. There's a single trial looking at high doses, which was a trend towards buprenorphine superiority. I think the takeaway is that neither of these were statistically significant, and these seem to be relatively equivalent treatments. Here again, looking at self-reported heroin use, there was a trend towards favoring buprenorphine in this study, but again, not statistically significant. So reducing heroin use seems to be relatively equivalent between methadone and buprenorphine. And then finally, looking at brief versus extended treatment. Should we be using buprenorphine in kind of a detox setting, or should we be using it for longer periods? This was a study of 152 young adults. They were 21 years and younger. And they were randomized to either 2 weeks of buprenorphine that was tapered or 12 weeks of buprenorphine. And here we see these are patients who were on the 2-week. Here's their urine drug screen positivity. Here's patients who were on 12 weeks and their urine drug screen positivity. You can see that they were much more likely to have drug-free urines if they were on buprenorphine than if they'd been on the rapid taper. They also had a lower self-reported opiate use. They were injecting drugs less, and they had a much higher retention in treatment. Their retention in treatment for the rapidly tapered group was 20% at 12 weeks, versus the group that was treated for 12 weeks had retention in treatment of 70%. So much higher ability to retain them in treatment if we treated them for longer periods. Probably 12 weeks even is not sufficient. For some patients, maintenance on buprenorphine, just like we have patients who are maintained on methadone, is probably the right model. My own practice is that I treat my patients on a stable dose for at least 6 months, requiring that they're in behavioral treatment, and hopefully in that period they're learning a lot of new skills. And then at 6 months we kind of check in and decide, are we ready to start tapering the medication, or do we feel like they need more time at the stable dose? So I'm going to turn things over to Mari here.
Can you hear me? Okay, great. Okay, so I'm going to take this over and talk about naltrexone, which is, I think of it as really the third alternative in medication-assisted treatment. So as Brinton said, it's a pure opioid antagonist. So it basically blocks the opioid receptors. So essentially, if you're taking this drug, then if you end up using heroin or opiates on top of that, they should have really no effect. So it comes in either daily oral tabs or an IM extended release monthly injection with a trade name Vivitrol. So the nice thing about this is that anybody can prescribe this, so you don't need to go through the training and to get the waiver from the DEA. So any of you can really start prescribing this right now. The cons, though, are that the patient really has to be completely off of opiates for 7 to 10 days. So they're in withdrawal at that time, so that's kind of hard to do. It's not as effective in relapse prevention or retention in treatment as methadone or buprenorphine because, as Brinton kind of showed you, it doesn't really have any of the agonist effects, and so the cravings tend to be much higher on this versus buprenorphine. A lot of the studies on naltrexone actually comes from Russia, where they don't offer buprenorphine treatment, so many of their patients have been successfully treated on extended release monthly formulations. So who should we consider for naltrexone? It's really for people who have already detoxed off of opiates. So they may be detoxed for a few weeks, and they don't feel like they can just do it without any medications. It is also indicated for treatment of alcohol use disorder, so potentially as concurrent treatment, it may be a good drug to consider. And really for people with either short or less severe addictions, I think may benefit from this medication. The cohort that seems to actually use this is health professionals that may have addictions, and they have to show a board that they're in treatment. They can show that I'm getting monthly shots, and that may be favorable for our licensing board. Or in the criminal justice system, they're mandated to get the shots every month. And then the main thing with the special precautions is these people, if they end up in the emergency room with a broken leg, none of the pain medications are going to work right away. So they really have to know what to do with that. Let the people taking care of them know that they're on this medication. Sometimes other forms of anesthesia has to be used for pain control. So I kind of see it as really a third line, but it is an option for people. So with any of these medication assistance treatments, it's really, really important to have a behavioral component to the treatment. And with buprenorphine treatment, it's really kind of mandated that you have to have the coexisting behavioral treatments to treat the patients. So these are some of the therapies that people might get. So cognitive behavioral therapy, contingency management, motivational enhancement therapy. And I don't expect you to know what they are, but just to kind of get familiar with some of the names. Some people can get family therapy, and then the 12-step and mutual aid groups, which one of them is smart recovery. Some people like smart recovery if they're kind of worried about the 12-step programs being too religious for them. The smart recovery tends to be a good option for them. So as Brinton mentioned before, the Drug Addiction Treatment Act actually passed back in the year 2000, so 16 years ago. So basically that act allowed physicians to treat opioid addictions in their office rather than everybody going to a methadone clinic. And the hope of this bill was to really expand access to treatment. At that point, less than 15% of the patients had any access to treatments for substance use. And as Brinton mentioned before, only 80% get it now, so we haven't really improved this capacity at all. And the uptake of physicians to get this training and offer this in their office has been kind of low and slow. So these are some survey data. So a survey 3 years after this passed was done. And at that point, 90% of addiction specialists had received a waiver, which is great because that's what their specialty is. And then 2/3 of them had treated patients with buprenorphine. But fewer than 10% of non-addiction specialists, so those would be internists, family practitioners, had prescribed buprenorphine. So in 2004, so 4 years after the law passed, there were only 2,518 physicians listed as having a waiver nationally. And then by 2008, it increased to 6,593. So about a threefold increase. But they also found that additional 9,000 people had the waiver, but they actually removed their name from the locator list. So when you apply for the waiver, you can either choose to stay on a list that any patients can look up to find you, or take your name off the list. And so as you can see, many providers actually take their name off the list. So again, in total increase, it went from 2,500 to about 1,500 in 4 years. And then currently, SAMHSA, which is a substance abuse agency, lists about 35,792 physicians that have the buprenorphine waiver, and that's nationally. So if you think about how many people have opioid use disorder, this is still a low number. So if you look at the people that have the waiver, most people have the initial 30 patient limit, so about 24,000. And so you can apply to get your patient limit higher. Once you've been using the buprenorphine for a year, you can get your limit to go up, and that's about 9,000. And then just this year in 2016, because of the problem with access, the Obama administration really has been trying to push for increased capacity, and they just passed a bill that you can go up to 275 this year. And so already about 275 providers have gotten that waiver to go up to 275. So this is in Oregon. So the blue line is the number of providers with a waiver in Oregon, and then with a 30 patient limit. And then the orange line is those with 100 patient limit. And then green is 275, and nobody yet in Oregon looks like has applied for the 275 limit. So initially in 2002 when these started, so we had, this is seven people. So we had 7 providers that had the waiver in Oregon. And you can see that it's a really slow uptake. I got my waiver around here. So I was definitely one of the early adopters. So I think this is like 17 is the number here. So there were about 17 people in 2005. Then it's sort of a little bit going up, but we see a nice increase here starting around 2013. And around that time, a lot of the county clinics, like Central City Concern, everybody who practiced there has to get a buprenorphine waiver. I think the OHSU Richmond Clinic does the same thing, where everybody who practices there gets a waiver. So I think that kind of put the uptake. And I'll show you later that this, I think, is actually a result of our project, that this jump from 2015 to 2016. So currently in 2016, we have 107 providers with the waiver for 30 patients, and then 35 with 100. I just recently increased my limit up to 100. So I'm in the 35 there. Okay, so that sounds good that we're increasing capacity. So this was sort of my back of the envelope calculation. So if you go back to the national data, I calculated if the providers treated completely up to their capacity, nationally we can treat about 2.3 million patients. But again, as you heard from Brinton, I think that's about the number of all the overdoses. So it's still not great. And even though people have a waiver, that doesn't necessarily mean that they actually prescribe this medication. So a survey in 2008 showed up to 32% of providers with the waivers have never prescribed. So the access is not really there. The survey in Vermont was in 2009, and Vermont is one of the states that actually had really early uptake of this treatment. So there they did a study looking at how many people have gotten this prescription. And they had found that 1964 patients received at least one buprenorphine RX, and that was in 2009. And 133 prescribers prescribed those. But actually 190 people had waivers in Vermont. So there were there was a whole bunch of people who were not prescribing. And then the average number of patients that the physicians treated was only 14.8. And it ranged from some people were only treating one person up to people treating up to 76 patients. And about half of them really treated less than 5 patients. So the realistic capacity, if you look at, use those numbers, is more like 518,000 nationally, and about 2,000 in Oregon. So again, it's still really not enough access and capacity. So we applied for this grant, and a lot of the reason that we came up with this was Brinton and I felt like a couple years ago, it really felt like we were the only providers that can do this treatment in the Providence system. Because we were seeing a lot of patients that were referred to us. It seemed like everybody who was in the hospital that had this disorder would get referred to us. Chemical dependency was referring to us. And I was getting to my 30 patient limit. And I was just wondering if any other clinics had providers that were doing this. And when we asked the medical directors at PMG, they basically said, no, I don't think so. I don't think anybody else is doing it. So our idea was to try to engage more primary care physicians to actually get the training and start doing this treatment. Because both Brinton and I really have found this to be one of the most rewarding parts of practicing medicine. Really seeing people who are down and out, have completely lost control of their lives, really regain that control. So we applied for the grant, and the goals of this project was to increase the number of PMG primary care physicians that can treat buprenorphine. We wanted to develop a pathway for referral from inpatient, emergency room, urgent care, to chemical dependency and primary care. We're also doing a cohort study to compare the effects of the early uptake clinics versus the late uptake clinics in terms of utilizations and outcomes. And we've done provider survey before, and we'll do an after intervention provider survey. So when we're thinking about what to do as our intervention, we wanted to see what's out there in the literature of potential barriers to getting the waiver. So these are two surveys that looks at some of the barriers. The first one by Netherlands looked at two cohorts of physicians. One was a Beehives program in New York, which was mainly a program to have HIV providers try to start using buprenorphine. And then the PCSS, Physician Clinical Support System, is a system where providers that are interested in this can get hooked up with experts. When they surveyed, the biggest barriers that they cited were the lack of training of clinic staff, access to behavioral treatments, adequate time for patient visits, access to support services. And then the new people who weren't prescribing didn't say this, but the people who were prescribing worried about adequate reimbursement for the treatments. This other study kind of showed similar things. This was done in New Hampshire and Vermont. They sent a survey to all family practitioners in those states. They found that 10% were already prescribing. 80% regularly saw patients with addictions in their practice. 70% thought that it was the responsibility as a PCP to provide treatment for opiate addiction. So it's always interesting that 70% think that it's a responsibility, but only 10% are doing it right now. So some of the barriers in this study, again, were inadequately trained staff, insufficient time, inadequate office space, and I think that's for the inductions. Lack of knowledge, time, or interest, mistrust of people with addictions, and difficult patient population. So we kind of looked at all these barriers and came up with our project intervention. The first thing we did was Brinton and I created an educational video with our experience and kind of our journey of how we decided to get the training and start treating in primary care, and with some of our successes with some of our patients. We spoke at the PMG medical director and clinic manager meetings and showed the video, answered questions. We built a provider toolkit and resource page on the PMG website. And the toolkit has workflows, visit templates, frequently asked questions, and then we got a lot of input from our behavioralists and pharmacists on our team, and how to incorporate their role in this treatment. And we have gone out to visit individual clinics at their provider meetings, and we've visited already 20 clinics. One is pending, and then 2 clinics deferred for a later time. But these have been very productive meetings, kind of both telling our story, answering questions, seeing what potential barriers also that they're citing. We set up a monthly conference call for topics and questions with experts, and that was to support any educational endeavors, or really if they had any questions. And then the grant is providing reimbursement for the training and a free CME day for them if anybody wants to do that. So with all these interventions, we did our provider survey early on in the project just to see what were the barriers that the PMG providers thought. This was distributed by email to about 300 providers, and we got a response of 102 providers. And if you look back at the other surveys that I mentioned, their numbers are around that range as well, 100 providers responding. So this is one of the biggest ones that in the literature so far. We found that 5 providers were currently prescribing with an average of 7.8 patients per provider in our system. And some of the interesting things that we found, so we asked, do you know what buprenorphine is? And 97% said yes. we asked, do you think buprenorphine should be provided in primary care? And 77% said yes, so it's similar to the other survey. And then we asked, are you likely to prescribe? And only 24% basically said somewhat likely, likely, or very likely. So again, we kind of have that disconnect of 77% feel that this should be prescribed in primary care, but only 24 are likely to do it. So this is what we're trying to improve. Some of the barriers that the PMG providers cited was that they thought this was a very challenging patient population. They were worried about the limited outpatient counseling options, worried about the time it takes to manage these patients, insufficient personal knowledge of how to do this treatment, concerns about diversion and abuse, limited behavioral medicine support in the clinic. Some people said low demand, and we did find this when we're talking to some of the clinics. They really didn't think they saw patients with opioid use, which was surprising to me, but I think some clinics feel that way. And then some, small numbers mention these things on the bottom here. So again, pretty similar barriers, but our projects has been trying to kind of mitigate these concerns and worries throughout. So, and kind of pleasantly surprising to me, we've had really, really amazing success with this project. So we started the project in February of 2016. And at that point, we identified 5 providers in 3 clinics. I think 2 of them were Brinton and I. One is a physician in Newburgh, and the 2 others are family practice physicians at the faculty practice in Milwaukee who are only prescribing in their Project Nurture program, which is a program to treat women who are pregnant with buprenorphine. So those were the only 5, we think, at PMG. But as of today, we now have 26 providers who have already gone through the training and have obtained their waiver in 13 additional clinics. And we have 14 other providers pursuing training in 5 additional clinics, and then 14 other providers who are potentially interested in 3 additional clinics. So you can kind of see, this is a hard slide to follow, but so the blue bars are the number of providers. This is the y-axis for that. So we started with 5, and we're up to, actually if you do December 1st, it's higher, so 26. And then the orange line is the number of clinics. So we went from 3 up to 13. So that's been really, really amazing engagement and uptake from all the PMG clinics. And we really found a lot of enthusiasm when we went to the meetings, to the provider meetings. And it's anecdotal, but the younger physicians were more likely to do this and get trained and start thinking about this, incorporating it into the practice. So the next steps and future directions of our project is we're building a smooth pathway from primary care to chemical dependency and back. We really think timely access for patients who are identified in the ER, hospital, and immediate cares to be referred right away to chemical dependency or to primary care for treatment is really important. The window of engagement is really, really narrow, and sometimes even hours for these patients. And if they have any inkling that they want treatment, we should try to provide it right there. What happens now is in the ER or in the hospital, they say, yes, I think we want treatment. And we give them a page with 5 numbers to try to call once they get out of the hospital or get out of the ER. And they just don't have the organization and whereabouts to actually make those calls. And making a call is not that simple either. Once you call, you usually have to talk to like 4 different people to even get into treatment. So we really want to try to make this as smooth as possible. Our cohort study has currently been approved by the IRB, and we are looking at the utilization outcomes, again, comparing the uptake clinics and the non-uptake clinics. We've really focused on the Portland service area, Hood River we went to, but we haven't really looked at other regions like Southern Oregon or Washington, but we hope that our method can be spread to the learnings in the other parts of the system. So I'm going to have Brinton come back and talk to you about the outcomes of her patients.
Just to give the outcomes of the 2 patients that I presented at the beginning. So my first patient was my 20-year-old who was using oxycodone, buying 150 milligrams daily on the street. So I met him in 2014. We started Suboxone quite quickly, and he's remained in remission. He's had no relapses in over 2 years with medication assistance with buprenorphine. He initially went to intensive outpatient treatment 3 times a week, and he continues to engage in Narcotics Anonymous weekly. Within 3 months of starting medication-assisted treatment, he had stabilized his life enough that he was able to move in with his girlfriend and his daughter and start parenting. And he is really a very proud and active parent to his daughter, which is amazing to see. He's now engaged to be married, and he and his girlfriend are expecting their 2nd child. He's kept a good job since he initiated treatment. He's no longer been unemployed at any point and is able to support his family. And we are actively working on titrating down his dose over time. My second patient that I presented was the 45-year-old who was abusing heroin for the previous 5 years. And she started buprenorphine in 2015. She's had 2 brief relapses on heroin that have lasted 1 to 2 days. She's been really honest with me when these have happened, has come in right away. And fortunately, that's allowed us to get back in the saddle really quickly and get her back into treatment and get her more functional. She also attended intensive outpatient programs. She got connected with a peer mentor, which has been incredibly helpful to her. And she continues to attend support groups 1 to 2 times per week. She's now in treatment for depression. Her self-esteem is improving. I can tell you, like, the first year that I saw her, she basically cried at every single office visit. And now she comes in, she looks happy, she looks engaged, she feels so much better about herself, and she feels really, really proud that she's been able to get clean. Family relationships have improved. Her husband is also in treatment, and so they both are in medication-assisted treatment and no longer using heroin. Their relationships with their sons have improved a lot. There still are stressors. She's now able to work part-time, and she's looking for full-time work, now feels confident that she can work full-time. She has been one of those patients who's felt like a maintenance dose is what she needs right now, so we haven't started tapering her. So I think both of these cases illustrate patients who've been very successful with medication-assisted treatment. For both of them, they were able to stop abusing opiates. They were able to engage in behavioral treatment. They were able to stabilize their lives and improve their functional status substantially. So as Mari said, for both of us, we felt this has been an extremely rewarding practice that we've incorporated into our primary care practice. And it really can change the trajectory of somebody's life. I think for that 20-year-old patient, imagine he has many years to live. And this has totally changed the trajectory of life for him to allow him to be functional, to actually contribute to society and to his family. The Surgeon General has just issued within the last couple of weeks a report on facing addiction in America. And this is really a call to action. And I think increasingly we're realizing that we need to address this epidemic. So many of the things that we've been talking about today are exactly what are in this report. So the first thing that they identify is that substance abuse must be identified in general settings, including primary care, psychiatry, and emergency care, and that effective screening helps to create individual treatment plans. This report really attacks the misconception that medication assistance substitutes one addiction for the other, and they very strongly call that unscientific bunk. They emphasize increasing access to medication-assisted treatment, including methadone, buprenorphine, and naltrexone, is crucial to fighting the opioid epidemic. And then substance abuse treatment is not the work of individual specialists, but should be treated by a mix of caregivers, including social workers, recovery specialists, nutritionists, just like we treat with multiple providers for things like chronic diseases such as diabetes and cancer. So in conclusion, we hope that this convinces you to think more about addiction as a chronic disease, that primary care, especially medical homes, can be an ideal environment for treating and providing medication-assisted treatment, that there is more need for access to treatment. We still have a big gap between the number of patients that need to be treated and access to treatment. Obtaining a DEA waiver is pretty easy. It's 8 hours of online training, and then you can get your waiver. That there are supports for primary care physicians, and including Mari and my project, you're very welcome to contact us if you are interested in this. And we are very happy to help both give you access to our workflows, et cetera, and just support you as you start out this practice. And that hopefully more collaboration will be coming with chemical dependency so that we can find the optimal treatment settings to treat patients. So thank you so much for your attention, and we'd be delighted to answer questions.
Brinton, another slide on the team.
Okay, and here's our project team. Sorry.
Talk a little bit about set point for opioid users. When people are doing Suboxone treatment, do you see their set point returning back to normal? That they have a lot of concurrent conditions like anxiety, depression, things like that. Is that affecting that at all?
So the question is that set point that changes in addiction in their brain, for instance, dopamine, does that change with buprenorphine? I think it stabilizes with buprenorphine because they're getting some stimulation of those opiate receptors, but they're getting some blockage. So it tends to stabilize, and most people tend to say that they feel much more normal. They're no longer feeling high, but they're feeling normal, and I think much more functional. They feel like they can work, et cetera. So does their brain go back to normal? I think we just don't know that data yet. We don't have the data.
I'm wondering about, is there any work right now to deal with the transition from inpatient to the outpatient setting? Because I think we're seeing a ton of people coming in with multiple complications, mostly infectious complications from their opiate addiction. They're often here for 4 to 6 weeks getting IV antibiotics. And we just give them a list of opiates, the methadone clinics, and they're kicked out and they come back because they're going to relapse. And I think, is there any plans for inpatient chemical dependency to help that transition to get people hooked up with either inpatient detox and then transition to outpatient setting? Or, is there, any work to help bridge those people? And because I think we're missing an opportunity.
So great question. So the question is, we have all these patients that we see in the hospital who maybe have heroin addiction, and they're coming in with infectious complications, endocarditis, epidural abscesses, et cetera. And we treat them for a really long time with great expense in the hospital, and then we send them out with a list of methadone clinics, and they relapse, and they come back. So yes, part of our project in the next steps is to create that pathway from the hospital, hopefully quickly into chemical dependency. And the hope is that this would be a seamless transition to chemical dependency, and then to longer-term treatment into primary care.
Yeah.
So getting them into these primary care settings. Mari, do you want
And
to
I think those patients actually, that are sitting around for 6 weeks, they should start treatment in the hospital. And then we can, follow up. And I think we've had cases that we did that. Yeah.
that would be the goal.
Hospitalists getting certified and doing this, or is there any push to get that happening?
So actually in the hospital, you don't really need the certification. Yeah, similar to methadone.
So we're actively working on creating that pathway with the chemical dependency program.
Yeah, so there are some actual studies looking at starting people on buprenorphine in the ER, and that actually increases the likelihood that they'll come for a follow-up appointment in a chemical dependency treatment.
Dr. Gilbert?
Brinton, 2 quick questions. One, you didn't say anything about the expense. So the buprenorphine, as I look it up here, is very expensive. So a lot of these folks, especially at entry, are financially challenged. So can you say something about that, and what tier is the drug in for the Providence Health Plan, et cetera? Second question, if there's time, is because your responders to these questionnaires say one of the things they worry about is the time commitment and the care of the patients. After the patient has entered into the program and you've made your initial relationships, Is there any hope for group therapy in clinics so you could more efficiently see groups of patients?
So a couple of questions there. The first was about the expense of the medication. And to buy this medication without insurance is relatively expensive. However, almost all insurance companies at this point are covering it. And I find, and Mari, maybe you can comment on this, that copay for them is often in the range of $10 to $20 a month. These are patients who've been buying 150 milligrams of oxycodone on the street, which is about $1 a milligram. So they've been spending a lot already usually, and this is usually much less expensive for them.
And there's a generic preparation, so it's sort of a generic copay.
And then your second question was on group visits. Actually, I think Mari and I have both found that for patients who are stabilized, these visits are not time-consuming. These are our standard, 15 or 20-minute office visits, and they're usually a quick, relatively quick check-in. This is not a really complicated visit. It's certainly much less complicated than many visits that we do in primary care. We have done some talking about whether the behaviorists in the PMG clinics, including our clinic, can do groups from the behavioral standpoint, to do kind of group behavioral therapies.
Yeah, so the Milwaukee Project Nurture Project, they do group treatments for their pregnant women, which really makes sense. So they do both the substance abuse counseling part as well as the pregnancy counseling.
And the chemical dependency program, and here Dr. Jessica Gregg was recently hired at Providence and is going to be expanding access greatly within chemical dependency to buprenorphine treatment. And her hope is that within chemical dependency, they can offer ongoing groups for patients who are on buprenorphine.
Thank you very much. We'd be happy to take questions.
Yeah, happy to take questions up here.
Yep.
Thank you so much.